Hey everybody, welcome. We're really honored to have a great presentation by Dr. Kenna Stephenson today. My name's Paul Bucky, and I'm the founder and executive director here at the International Foundation of Biomagnetics, and that's the nonprofit tax-exempt organization that teaches and shares biotouch healing around the world. So we are really honored to have Kenna here share a lot of the research she did with BioTouch. She's passionate about BioTouch, and I'm just going to give you a little intro about her and a little bit about her history, some very interesting little points in here, and then we're going to let her do her presentation. So Kenna Stephenson, a family physician, author, teacher, and researcher, thrives on helping others achieve well-being. At age 5, she declared her desire to become a physician. As a Texas teen, she worked in cotton fields, then excelled in fast food at KFC. And following her 18th birthday, she eagerly became a certified nurse's aide. She received her last nurse's aide paycheck on graduation day from medical school. In caring for over 100,000 patients in diverse settings, including, I think it's Murray in New Zealand, under triple canopy jungles of Central America, inside a mobile unit traversing Texas minefields, and on Paramount picture sets, along with private practice, community, global, and academic medicine, she fulfills her passion for exploration and adventure. A native Texan and honors graduate of the University of Texas at Austin, she completed the Doctor of Medicine degree with research honors at Texas Tech University Health Sciences Center, which included a student fellowship at the National Institute of Health. Her residency at the University of Texas Health Sciences Center culminated with the Residence Resident Award. Her career encompasses undeserved areas of Texas, Arizona, Central America, Southeast Asia, and New Zealand. Kenna's research has been featured in Family Practice News, Cardiology News, OB/GYN News, Medscape, UK News Digest, and Cleveland Clinic Heart and Brain Summit. Her women's health research is included in the European Society of Endocrinology 2025 Clinical Practice Guidelines and recognized in a 2023 Mayo Clinic review called Addressing the Missing Links in Cardiovascular Aging. She serves as an associate professor of family, community, and preventative medicine at the University of Arizona College of Medicine, Phoenix, and is the founding medical director of Team 5 Medical Foundation. Kenna's book, The Gospel of Women's Health, Awakening Athena Again, has received international acclaim. We are honored to have you, Kenna, and we're just going to let you take it away.
Thank you, Paul. It's great to be here. I'm excited about everyone's interest in our findings with brain spectroscopy and BioTouch. This presentation will probably run about an hour with a question and answer session at the end. And the slides are very dense because part of the reason for this meeting today is to invite research collaboration and invite researchers who are looking for touch modalities and ways to help patients. And so I know that some of you have perspectives as a BioTouch practitioner, or maybe you have a curious interest in BioTouch, or maybe you're a physician, a nurse, physical therapist, physician assistant looking for new, novel ways to effectively help patients with pain and stress relief. Next slide. Touch has been part of medicine since ancient times. We know in Egypt there are texts that mention touch as a treatment modality. We know that Hippocrates himself prescribed and used touch for different diseases. Next. In 1867, the French physician and musician Dr. René Laennec invented the stethoscope. Now, before that time, physicians placed their ear directly on the chest of the patient to listen to the heart. And when Laennec presented this device, there was a lot of opposition by physicians, feeling that it would distance them too much from the patient. Next. And look how far we've come. I hear from patients every week that I'm the first physician that has actually conducted a physical exam, that they're very appreciative that I took the time to do a neurological exam, do a neurosensory exam, use my stethoscope to listen to their heart and lungs. And I feel that many are missing out because the hallmark of medicine is the history and the physical exam. Norman Cousins had this to say: physicians celebrate the CAT scanner while patients celebrate the outstretched hand. And Voltaire had this to say: physicians prescribe drugs about which they know very little, for diseases about which they know even less, for human beings about which they know nothing at all. Next. Our patients, however, are often pleading for touch. This is a patient that had a very serious illness and he had a lot of pain. And I was assessing his lungs and I placed my hand on the back of his chest and he cried out, "Oh!" And when he did, I released my hand and he said, "No, don't stop." And so I put my hand back and he said, "That feels better than any painkillers." And we know in other settings, some of you may have had the setting where, as a mother or as a teacher, where a child is hurt and crying and they cry, 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 but the instant they run to your lap and you hug them up, right? Or the instant they come and get in the car and you able to make that physical contact, it can calm them down. And they actually did a research study of this where they had infants and their mothers and they separated them by a curtain partition. And then the baby was in some distress and the mother used her voice to try to calm the baby. The voice didn't work. Then they tried lifting the curtain where the baby could see the mama, just the side of the mama. Is that going to calm the baby down? No. But when the mother was allowed to reach under the curtain and touch the child, then their sobs subsided. Then they were soothed. And so we know that touch is vital to the human experience. However, how do we touch patients? How do we do it in an easy, accessible, practical way that's replicated across cultures and across time? I found my answer at St. Elizabeth of Hungary Clinic in Tucson, Arizona. Next slide. I was the associate medical director at this clinic, and at that time, pain was considered a fifth vital sign. And so we always ask our patients about pain. And of course, we were heavily encouraged to prescribe pain medication, including opioids at this time in American medicine. When I would ask the patients about pain, many of them said, "No, I just see Sister Mary. No, I just have BioTouch." Some of these patients had severe musculoskeletal pain. They had severe conditions, and I knew they must be in a lot of physical pain. And I was perplexed by this concept of BioTouch and what Sister Mary was doing. I had not learned anything about it in my medical education. I asked the medical director about it, and he said, "Well, you'll just have to ask Sister Mary." But it seems like our paths never crossed. We were very busy. We had over 400 volunteers, 16 medical exam rooms, 9 dental rooms going. But one day, I came to work. I had a severe migraine headache, and like any good doctor, I went into the sample closet to see what I could find. There wasn't anything there. I wondered how I was going to make it through my day. And a patient canceled, and so I went to sit in my office for a moment and rest. There was a knock on the door. A lady entered. "Hello, I'm Sister Mary. I see that your patient canceled and you have a few minutes. I would like to introduce you to BioTouch." Well, I said, "Okay." She said, "Are you having any pain or distress?" And the scientist in me said, "No." And she said, "Well, I'll just do the greeting in the headset. That's what we usually do for outreach health fairs and when we're just introducing people to BioTouch." As she touched my head with this very light, gentle touch, the pain began to dissipate, and then it disappeared completely. And I thought to myself, with the observations I had seen in the patient population and my personal experience, I want to investigate this. I want to learn more about this. Next slide. So here is Sister Mary performing BioTouch. And the history of BioTouch, for those of you new to it, is that it was a technique developed in the 1970s by Norman Cochrane in a Colorado mining town. And he was spontaneously doing this to help others with pain and stress. At first, he thought just he himself could do it, but then he realized that he could teach others which points to touch and how to touch them, and they had results too of the recipient having pain or stress relief. And so in 1991, the foundation was established. You can read all about it at justtouch.com. Next slide. So life took me to the University of Texas Health Center, and I had some seed money, and I wanted to use the seed money to research this modality. The BioTouch technique is characterized by a very light, butterfly-like touch on the skin using the first finger and the second finger, or the ring or the index finger and the third finger of the hand. There are 17 sets of points that can be touched, and the touch is held for about 6 to 8 seconds. And then there are also slow stroking touches between some points. Next slide. When we compare different types of touch, we see there's biotouch, there's Reiki, there's therapeutic touch, and there's kangaroo or grooming or caring type touch. And you can see the different characteristics of the modalities. BioTouch does not require any type of meditation, centering. There's no real conversation or cognitive component at all. No co-speech is required. There's no reading or unruffling of any type of energy fields. There is always skin-to-skin contact. And there is no hierarchy or attunement or authority. Someone that just completed BioTouch practitioner training is just as effective when they use the technique as someone like Sister Mary that had done it for decades. Next slide. When we look in the animal world, we find that touch is vital to their well-being and even to their survival. Dr. Jane Goodall, in her vast amount of research of the chimpanzees in Africa, taught us so much about this, and that grooming behavior is not just about removing debris from the fur or the skin, but some of these grooming sessions might last for hours. And that when there was a polio outbreak, one of the adult males who was paralyzed from the waist down, he drug himself a long distance in order to attend a grooming session with other chimpanzees. We know from Harlow's monkey studies where they took the monkeys and separated from their mothers, and then they constructed a wire mother monkey with the food, and then they constructed a soft mother monkey. We know that those little juvenile monkeys, they hung out with the soft mother monkey most of the time. They only went over to the hardwired one to get a bite to eat or drink. And so this type of tactile interaction is innate and needed, and it's vital to psychosocial development as well as the immune system. Next. Saul Schomburg at Duke University is recognized. He's won numerous awards, including the Golden Goose Award for his work in touch beginning in the 1970s. Dr. Schomburg was interested in an animal model of what happened in the neonatal ICU. In the late 70s and 80s, we were able to resuscitate babies much younger and much smaller than previous Yet the babies often struggled with immune problems, with growth and development problems. And so in this animal model, he took rodent pups, and when they were 10 days old, they were isolated from the mother and they were given adequate food, adequate water, controlled temperatures. But with the deprivation from the mother, he saw changes in immune factors, changes in cortisol circadian rhythms, as well as gene expression. And and he and his lab team were looking at how to reverse this. What were factors that would reverse these changes? And his lab technician said, well, I noticed that in the natural environment, the mothers are always licking the pups. They seem to be licking them quite a bit. What if we took a paintbrush and dipped it in some water and we just rubbed it along the fur of the pups to see what would happen? So they did it, and they were amazed that this type of touch, this light touch, did reverse the deprivation changes. And using this knowledge, they then introduced this type of light, caring touch into the neonatal ICU environments. Whereas before, the babies just received what we might call intentional touch, where a tube or lead or wire was adjusted or their body position was adjusted. With Dr. Schomburg's work, they began receiving caring touch, and then they began introducing the parents into the ICU with skin to skin contact in that kangaroo caring type touch. And we begin to see a lot of improvement, significant improvement in growth and health outcomes in these neonatal environments. I talked to Dr. Schomburg when I was designing the studies at the University of Texas Health Center, and he was such a gracious individual, and I'm thankful for what I learned from him. Next slide. So life took me to the University of Texas Health Center, and I used the seed money to begin the BioTouch project. Paul, Bucky, and Sister Mary came from Tucson to our facility, and over a 2-day training, nearly 30 physicians, nurses, physical therapists, volunteers, massage therapists, and volunteers became certified in the BioTouch technique. Next. At that time, BioTouch was classified and still is classified as energy medicine by the NIH. The idea was this therapy affects the energy fields of the human body, utilizing a butterfly light touch to intensify and enhance the flow of energy between the practitioner and the recipient. Next. So we, with this trained team, discovered that BioTouch was safe and that it was effective. We utilized it in both inpatient and outpatient settings. And we designed our first study. We enrolled over 100, and I believe we enrolled about 138 patients in the first study. Next slide. In that study, we were looking at the effects of BioTouch on quality of life. And we had a hypothesis that we would see improvement in the bodily pain index based on what we had observed empirically from Sister Mary's work at St. Elizabeth's of Hungary Clinic, from the Tucson Center that offered BioTouch treatments to patients, and those testimonials. But we were astounded to see that there was a statistically significant improvement in all domains of the quality of life scale at 8 weeks. This was with a BioTouch treatment once weekly. Then BioTouch was stopped, and 4 weeks later, we assessed the quality of life again, and we found a sustained benefit in 4 of the domains. I'm sorry, 5 of the domains. So you'll see the double asterisk there. Those 5 domains were vitality, social functioning, the mental health index, the bodily pain index, and general health perception. So there was a duration of benefit. Next slide. We presented our findings at the American Association of Integrative Medicine annual conference. Next. Our follow-up study was looking at a more homogeneous patient population. I've been I've been fascinated with menopausal, postmenopausal women throughout my clinical practice and career. And so I wanted to study this touch modality in this group of women. And so we enrolled this group of women, they were between the ages of 64 and 82 at the time of enrollment. And we compared a touch group and a no touch group and measured the effects on immune factors, inflammatory factors, hemostatic factors, the quality of life scale, as well as cortisol circadian patterns. Now, the no touch group was a real challenge in asking these women not to have any physical affection, hugs, handshakes, massages, pedicures, manicures for the 4 weeks of the no touch. And some of my patients actually made a sign that they wore around their neck so they could avoid touch. Now, most of these women lived alone, so in their household, it wasn't a problem for them. And I did have to make one exception, however, because I was in the state of Texas and I'm a native Texan myself. And in Texas, it's often said the higher the hair, the closer to God. And a woman says that her hairdresser is her healer. And so some women have standing hair appointments for generations. And so I had to make the exception that they could go to the hairdresser if they had a hair appointment. But again, we wanted no scalp massage during the hair appointment. Next slide. So we looked at multiple factors. I'm just going to highlight a few of those. Here's Dr. Anna Kurdowska. Dr. Kurdowska was vital to this research. In this particular factor, you can see we were looking at immune signaling factors, both at baseline and 72 hours after BioTouch. I believe that one of her postdocs, Dr. Krupa, is joining the presentation today, and I want to say thank you. I know that your team was so helpful in getting those specimens and handling the specimens and performing the assays and helping us. Sometimes I might have some specimens and then I had rooms full of patients and couldn't get over to the biomedical lab, and Dr. Krupa and others came and helped in those spaces. Thank you. Next slide. We looked at cytokines, and I just want to highlight one of the cytokines. We saw an increase in interleukin 12 levels within the touch group, in the BioTouch group. You can see that the levels nearly doubled. In the green is the control, and in the orange is the BioTouch group. Next slide. This is important because interleukin 12 helps protect against the development of tumors, also helps protect against infections such as the common cold and other viruses. And I have a table here showing some of this. Now, with normal aging, we see a profound decrease in interleukin 12 levels. We also see interleukin 12 levels drop within settings of extreme physical stress, psychological stress. So I reflected back on this data when we experienced the pandemic of 2020. And I just wrote about this, and I have the quote over here to the right of the slide. This finding of increased interleukin 12 is paramount within the context of the global pandemic of 2020 and resulting profound touch deprivation. The clinical observations of a cancer surge in 2021 to 2023 may not solely be attributed to lack of screening access and are likely related to deficits in this cytokine. Next. We also investigated gene regulation, gene upregulation, gene downregulation immediately following a BioTouch session. We took skin biopsies of the patients and we sent those to Genome Explorations Laboratory. They harvested the fibroblast and looked at up and down regulation of various genes, very similar to Dr. Schomburg's work as it related to his work with touch and genes. And we presented these findings at the American Association of Integrative Medicine Annual Conference 2004. Next slide. So here is the genetic fingerprint of BioTouch. So if you take, those of you that are BioTouch practitioners, you know exactly what to do. And if you take your hand and you place your fingers right over the screen, it's almost as if you can cover those touch points, right, with the index and the middle finger. So in the red are the genes that are downregulated, and the green are the genes that are upregulated. And over here in the pie chart, it can show you some characteristics of the genes. About half of them had to do with cell growth, maintenance, metabolism, and then others had to do with response to stress, with response to stimuli, both internal and external. This was very exciting for us to see the genetic fingerprint of BioTouch. Next slide. Our next study looked at a elderly patient population, both men and women. Average age was 85 years, and they received BioTouch once a week for 24 weeks. In one group, the other group didn't get the BioTouch. Now, they were not touch deprived, they just didn't receive BioTouch. Then we crossed them over. During the study, we looked at biomarkers including insulin-like growth factor, interleukin 6, tumor necrosis factor alpha, fibrinogen, C-reactive protein. We also looked at cortisol circadian rhythms and the quality of life, SF36. And again, we saw favorable changes and no adverse effects of BioTouch. Next. I've taken BioTouch into the boardroom. There on the left, I was asked to present to the board at the University of Texas Health Center because they were very intrigued and curious about this type of BioTouch research that we were performing, and also out into the community. So over on the right, this is an elementary school where the school nurse and some of the teachers became BioTouch practitioners, and they brought it into that setting. It has application across a diverse group. Next. We took BioTouch into medical missions with Tejas Missions and with Team 5 and other groups, and I've seen it offer benefit in pain and stress relief. But I remained intrigued and curious as to what was happening in the brain with BioTouch. Next. Most of the studies looking at touch or energy modalities involved an MRI. Now, I don't know if any of you out there have ever had an MRI, or maybe you know someone that has had an MRI, but going into an MRI scanner is a fairly stressful experience. It requires that the patient lie flat on their back, that they remain very still. It's extremely loud environment as well in the MRI. And so I felt that would be difficult to investigate BioTouch using an MRI scanner because the patient would not be in a natural posture, and it would be difficult and extremely expensive to get this information. But what is happening in the MRI scan is they are looking at bold signaling. So you can go over to the far right, and that bold is blood oxygen level dependent changes. And that's what they're measuring in these studies. Next slide. So I became aware of a portable outpatient type modality that could give us this information. We're looking at the neurovascular unit. In the slide here, the white is the nerve or the neuron, and the red is the blood vessel. That's what we want to look at. What's happening there? Next. And OB Labs device looks at what they call the activated brain by measuring oxygenated hemoglobin and deoxygenated hemoglobin around the neurons in the prefrontal cortex. And this is simply referred to as cerebral hemodynamics. Next slide. You'll see these wavelengths as we go through the presentation today. And so the OB Lab device uses near infrared technology, and the wavelength is between 760 and 850 nanometers wavelength for those physicists out there that want to know those details. In this diagram, the red represents the oxygenated hemoglobin and the blue, the deoxygenated hemoglobin. Next. In Japan and in Korea, this technology is used at the bedside and in outpatient clinics. And you can see on the far right, there are multiple publications as it relates to looking at different clinical conditions and using the NIRS or near infrared spectroscopy technology. Next. So I wanted to obtain this device and use it to study BioTouch. And I found the contact information for OB Lab and I wrote them this letter. You can see the date of this letter is 2022. And they answered my inquiry with a price list that was far beyond my budget. Just the device itself, I believe, was around $39,000, and that did not include accessories. That did not include software, which I believe was around $6,000, and up and up and up. So super expensive price tag on this. But I kept checking in with them periodically and asking them, where can I go and observe this? Because I just thought if I could just go to a lab and see it, I could see if it would work for our purposes. And then in July, Christmas came early, Christmas in July, when I got the next letter. Next slide. Dear Dr. Stevenson, thank you for getting back to me. We don't know anybody in your area that you might go and look at the system with, but we can provide a loan system free of charge to you for 2 weeks so you can test this device and see if it will work for your needs. Now, before I said yes, I said, does this include the software too? And they said yes, because I've used devices where you don't get the software and then it doesn't really help you much. And so they were very generous in offering this. And so my next phone call was to Paul Bucky. Next. I said, Paul, we've got this opportunity. Do you think we can get a group together and measure what's going on during BioTouch in the brain? And Paul was talking, and then suddenly he became very quiet. And he said, there's this huge owl that just appeared about 3 feet away from me. It's just staring straight at me as we're talking. He said, I think it's going to have to be a yes. And so he said yes and got the group of volunteers together, and it happened in August. Next slide. The device came in the mail, and of course, like any good investigator, I tried it on. Next. And I realized that there was going to be a nurse tattoo, a temporary tattoo on the forehead of the women. And remember my research in Texas, so I knew that I needed to prepare the patients that they might have these little indentations for a little while afterwards. So maybe not go to a party right after they have their NIRS scan. Next slide. Those little round circles are where the emitters and the detectors, where the source and the channels are uh, putting the flow of light at about a 3 centimeter depth into the prefrontal cortex and measuring those bold changes that I talked about earlier. And so you can see a schematic here of the various channels as well as the various regions related to the channels. And so there are 8 regions: the dorsolateral prefrontal cortex, right and left, the ventrolateral prefrontal cortex, right and left, the orbital frontal cortex, right and left, and the frontal polar prefrontal cortex, right and left. And now you understand why we use abbreviations in medicine. I'm going to teach you some today. Next slide. So here's a schematic of the brain. And so you can see that frontal lobe and the temporal lobe. And remember the photo of me wearing the headset. So it would go across the forehead into the temple area. So we're primarily looking at area 13 and a little bit of area 2. And you can see that those areas have to do with memory, with emotion, concentration, planning, judgment, emotional expression, creativity, inhibition. Next slide. I hustled down to the center and was greeted by our volunteer team of BioTouch practitioners. On my right there is Eileen, and then we have Bev, who's the co-director of the foundation. Then we have Connie and Anne. Next. We also had Jeff and Shelley coming in as medical assistants and helping with the clinical components. Next. Here is the first near-infrared brain spectroscopy scan. This is when we were getting some of the coordinates set. And so you can see these are our 2 volunteers, Eileen and Anne is the recipient in this photo. Next. As we were calibrating too, Paul gave Jeff his very first BioTouch treatment, and he did the headset. And this is a little video, so you can see on our tablet as we're looking at the prefrontal cortex changes in that oxidized and deoxidized hemoglobin. Paul, you want to play the video? It's just about 7 seconds long here. There you go. Next slide. Next slide. So we looked at a cohort similar to the group that I had looked at in Texas of menopausal, postmenopausal women. This group was between the ages of 50 and 92. And we obtained a lot of information about them, their education, their marital status, their household living conditions, their dietary practices, sleep, physical activity, social media use, employment, medications, and hobbies. We also performed an anxiety state questionnaire on the day of. And we found that none of these factors that I mentioned above had any impact on our NERSIT findings. Now, you will see some of the volunteers in this presentation because I want you to see what the device looked like and what we were actually doing in the center. And we do have permission from all of them to share their photographs for educational purposes. Now, but everything has been de-identified as it relates to any of the results that are being shown in the presentation. Next slide. We measured their blood pressure. Next. As well as a dynamometer reading. For those of you that aren't familiar with the dynamometer, you can see Shelley getting the reading in the volunteer here as she's squeezing this device as hard as she can with her dominant hand. And I've looked at dynamometer readings in my practice for many years now, and it's based on the Dunedin clock genes, which correlate with the ability or the grip strength measure of the dynamometer reading. So it's kind of a poor family physician's way of looking at Dunedin clock genes. Those came from a study in New Zealand, and I became aware of this study when I was practicing in New Zealand. It was a nature versus nurture type study where they enrolled over 1,000 babies born in the year 1972 and followed them for 5 years. But the study kept going on and kept growing as investigations kept growing as clinical technology grew. And long story short, in 2022, all those babies had their 50th birthday. They're still enrolled in the study. And it's a fascinating study as it looks at nature versus nurture and now pacing of aging. And the best way to learn about this study, I think, is on YouTube. Next. So when we looked at the dynamometer readings by the age group, we divided the group into 50 to 64 and 65 and older. We found that the 65 plus had slightly lower dynamometer readings. Next slide. And this seemed to correlate with physical activity. So more physical activity in the 65 plusers, the higher their dynamometer reading. And you'll see that little yellow dot way up at the top. Yes, we did have a dynamometer reading at 46 kilograms. Next slide. We also saw a difference in pulse pressure between the two groups. Next slide. But we did not find that this difference nor the dynamometer difference impacted what we measured as the frontal integral or the temporal integral as it related to the cerebral hemodynamics. Next slide. So the way that we structured the day was the ladies had two cognitive tests, and then they had biotouch. And for the biotouch, we did what Sister Mary did to me the first time I ever had biotouch. That was the greeting and the headset. And so the first cognitive test that we did was the verbal fluency test. The reason we did the cognitive test is because we wanted to ensure that we were using the device properly, that our population and our results in these two tests seemed to match what was in the scientific literature. And that would give us more confidence about our conclusions should we find anything in the biotouch analysis. And so the verbal fluency test, some of you, if you've had cognitive testing, you may have done this test, but it's a test looking at somatic memory, working memory, inhibition of intrusive and repetitive thoughts. And we would, while the patient was being scanned, we gave them a letter, and then they were to say as many words that they could think of that started with the letter during a specific amount of time. Next slide. And here is the cerebral hemodynamic schematic of what's going on during the verbal fluency test. Remember the curves that I showed you earlier? You recognize them now, right? Deoxidized hemoglobin in blue, oxidized in red. Next slide. So when we looked at total word counts by the age group, we didn't find any significant differences. And this group had really good word counts. They performed very well on this test. One of the letters that we gave them was S. And I was writing the words down during the verbal fluency test. And this was August, as you recall. And I really had to keep from laughing when quite a number of them said Santa for a word that starts with S. So Santa was on their mind even in August. One of the participants, when we asked her to words with S, Sue, cells, sea, shells, sea, shore. Ah, isn't that very, very clever? And I was holding my breath and hoping that nobody said, and nobody did say, Mary Poppins' favorite word, supercalifragilisticexpialidocious. Next. So we did not find that the anxiety state influenced the verbal fluency. Next. And when we looked at the temporal integral measure of the cerebral hemodynamics, During the verbal fluency task by age group, we didn't find any significant differences looking at our early elders and our late elder groups. Next. And so the optical topography analysis of the verbal fluency test was right in line with what we saw in the research literature as it relates to this population. For the physicists here, the integral and the centroid are simply units. The integral value is describing the size of the hemodynamic response, and the centroid value is the index of time changes throughout the task. Next slide. So every one of the participants received a personal optical topography report, and the group appeared very normal as it relates to this. Next slide. Now, our second cognitive task was the Stroop task. This is a task looking at incongruent stimuli, looking at cognitive control, and looking at sustained attention. And so during this task, you can see on the screen here, this is our other volunteer, Ivan. Ivan's a software engineer and helped with data entry and with statistical analysis and vital member of our team. Thank you, Ivan. And he's holding the tablet here. And so the patient is presented with a word, and that word is in a color. And underneath the word are two boxes. One box is the color of the word, and the other box is the word. And so you can see here the word green, Green, but you can see that the color of the word is yellow. And so the patient for the correct answer would touch the screen, would touch yellow. So I hope I've explained the Stroop test to you sufficiently. Next slide. And when we looked at our Stroop task results in these 8 regions of the brain, we found very good concordance with what is reported in the clinical literature, that the activity is in the right ventrolateral prefrontal cortex. This is looking at oxygenated hemoglobin. Next slide. And this is looking at deoxygenated hemoglobin. And so both with the verbal fluency test and the Stroop test, we had findings that were reproducible and in line with the literature. And so I was so very eager as we got to the BioTouch analysis. And my hypothesis was that we were going to see the BioTouch hot point, so to speak, in the left dorsolateral prefrontal cortex, because that seemed to be where analgesia or pain relief lived in a lot of the clinical research around pain stimulus and pain stimuli studies. And so Ivan and I got together and I said, look at the left dorsal prefrontal cortex first. Come on, let's look at the left and let's see it. And next slide. So drum roll, here we go. And look at that. They look pretty much the same, don't they? When you look at the left box and the right box and that red line in the box, they're right in there together. No significant change. Not at all. So I was pretty disappointed with this because I was hoping we were going to have a real quick, easy find and move forward, but we didn't. And so our clinical research team did what every research team does, and that's look at all of your data, look at everything, not just that area related to your hypothesis. And so that's what we did. Next slide. So when we look at all of the regions, we started seeing changes in the orbital frontal cortex, or the OFC. This shows the change in the oxygenated hemoglobin in the OFC. Next slide. This is looking at deoxygenated hemoglobin, and where do we see the activity? In the OFC, orbital frontal cortex. Next slide. When we look at total, both oxygenated plus deoxygenated, we see the activity in the right and left prefrontal cortex. And I want to give a shout out thanks to Dr. Ding. Dr. Ding is a presidential professor at the Stephenson School of Biomedical Engineering in the University of Oklahoma. And I think probably the reason that he was willing to help me, as I read some of his fascinating papers on this and wanted to communicate with him about our data, was because of my last name. And when I got home that night at dinner, I asked my husband, "Hey, any of your relatives have anything to do with the University of Oklahoma School of Engineering?" And he didn't know of anybody. But thank you, Dr. Ding. So we have our answer. It's in the OFC. So I wanted to look closely at the waveforms in the OFC. Next slide. First, let's talk about the orbital frontal cortex. It is involved in decision making. It's involved in expectation, adaptive learning, sensory integration, and mediating reward and fear related behaviors. And the body of evidence shows that the mid anterior OFC, which is where we see more of the activity, it tracks subjective pleasure in neuroimaging studies, and it's sometimes termed a hedonic hotspot. Next slide. When I looked at the literature related to pain and the OFC, I found this very elegant study written by some of the most brilliant minds in medicine as it relates to the brain and pain. And if you're having trouble sleeping one night, you can go online and you can find this study and read all about it. But I'll just summarize it briefly to say that what they did in this research study is they were shocking the foot of the patient while they were lying in an MRI scanner. And each patient was given a currency value equivalent to about 68 cents or 40p in the UK. And then they would make a bid as it related to receiving a shock stimulus graded as low, medium, or high. And then a roulette wheel would roll around, revealing the market price for pain relief at that point in time. And just to condense it all, I would say that the appraisal of pain, as well as the value related to aversion and avoiding that pain, all of that processing took place in the OFC. And it wasn't just a quantitative record of the type of pain stimulus, low, medium, or high. And so pain processing is in the OFC. Next. Uh, in 2023, we had a follow-up on that first elegant work looking at valuation of pain, where they actually put intracranial neural markers in the brains of 4 chronic pain patients and looked at where they experienced both acute pain and chronic pain. And you can see the OFC and see all the little red dots in there. That's where it's happening in the orbital frontal cortex. Next. Another study looked at lifestyle, 2 lifestyle factors, meditation and exercise, and they found using NERS technology that both meditation and exercise activate the OFC, and they termed this mental refreshment. So we see this potential for mental refreshment of BioTouch. Next slide. So, because we knew the action was in the OFC, we looked more closely at the actual waveforms that were being generated in the channels of the OFC. And so I'm just going to show you some waveform patterns here. We'll flip through these pretty quickly, but I think that you will start to see the similar pattern as we did as investigators. This was during the BioTouch task, looking at the OFC channels. Next. Next. These are all different ladies. Next. 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 Now, you say, well, maybe they're just always that way. Maybe their waveforms in the OFC are always looking like this because maybe they're meditators or something. Well, it is true that 9 of the 32 do practice meditation between 1 and 5 hours a week. But when we looked at the OFC during the other task, remember the verbal fluency task and the Stroop task, look at the waveforms. We sure don't see that nice sinusoidal coherent pattern. Next slide. This is during Stroop. Next slide. So we have termed this coherence based on coherence as used in physics, which is the generation of an ordered distribution of energy in a wave form. I think you'll all agree with me, this is coherence. And coherent energy fields are interrelated and they act to amplify and mutually reinforce each other. And isn't this somewhat the mission of BioTouch, Paul, as it relates to the social benefit of BioTouch? As we look at this observed coherence and we saw the synchrony, even intersynchrony between the waveforms. And these weren't that they were all on the same day. They were on different days. And we also rotated 3 different BioTouch practitioners. And we saw this type of synchrony, this type of coherence. And we believe that this observed coherence during BioTouch suggests a role for the human wave theory of consciousness. And I'm working on this right now with Dr. Michael Pravica at UNLV. Next slide. The HeartMath Institute, if you want to read more about coherent rhythm patterns, is a great resource, and I am certified in HeartMath. This is from one of my courses with HeartMath, but I just want you to look at those waveforms here. Here, they're looking at not the brain, they're looking at the heart. They're looking at heart rate variability, incoherence versus coherence. And you can see that pattern on the right is similar to the pattern that we saw during BioTouch. Next. HeartMath Institute defines coherence as the state where the heart, mind, and emotions are in energetic alignment and cooperation. An optimal state where the heart, mind, and emotions are aligned in sync. The immune, hormonal, nervous systems function in a state of energetic coordination. They say this is a #1 tool for healing. And we think of coherence as a simultaneous state of relaxation, readiness, and revitalization. I think that BioTouch does offer that state of readiness, relaxation, but also revitalization and readiness. Now, we didn't just confine our investigation to this group of 32 women. Now, for the group analysis, we did, but I just want to show you some other data here to give you a concept. And then we're going to look at the final analysis of the results. So we've got about 10 minutes left in the presentation here. I know this is a very, very busy slide, and this is looking at that oxidized, deoxidized hemoglobin, but I just want you to realize that there are 8 boxes here, and all of these are looking at the orbital frontal cortex, or the OFC. And you'll see at the top of each one of the boxes is a task. So you see task 1, 2, 3, and so forth. And then you see inside each one of the boxes is an orange square and a blue square, and they seem to be at different levels. So I want to draw your attention over to the far right. If you look down and you see task 4, task number 4, that's about midway to the far right. And you'll notice on task 4, you see a wide variation, a wide gap, right, between the blue box and the orange box. That's a pretty big space compared to those others. So I want to show you the waveform during, I'm sorry, that's task 6. I said task 4, that's task 6, where you see the big gap between the orange box and the blue. That's pre and post task. So next slide. Here are the waveforms during that task. You can see that they're incoherent, they're chaotic. And that task, in case any of you want to replicate it when you get home tonight, is ice water immersion of the hand. So you can get yourself a bowl of ice water and put your hand in there and hold it in there for a while, and you're probably going to have waveforms like this in your OFC. Next slide. So I believe that BioTouch is a wave therapy. Upper slide, incoherent, chaotic, pain. Lower, you see the coherence, rhythm of BioTouch in the OFC. Next slide. Our final analysis was looking at functional connectivity. So those of you that are in the neurological space, you'll know what functional connectivity is. And I'll share more about it in the next slide. But we saw that functional connectivity is significantly increased during BioTouch for 6 out of the 8 regions of the prefrontal cortex. Functional connectivity, I can give you an example. It would be like communication type systems. And so we know that areas of the brain that are in close proximity to each other easily communicate. Um, but what if they're further away, like on one side versus the other side, or in the front versus the back? So an example this might be I toured the Midway in San Diego, California a couple of years ago, and that Midway ship is an aircraft carrier, and they showed us all these huge flags on the deck of the ship and how they used flags to communicate with other ships. And so, if there is a ship in close proximity that can see the flag, they can respond to that type of communication. But let's say there's a radio transmitter on the ship, and with the radio transmitter, they can communicate to ships that are many, many miles away that can't uh, visually see the actual material flag. And so we see that there's enhanced functional connectivity where parts of the brain are able to communicate that aren't in the same geographic proximity. This functional connectivity is enhanced. Next slide. We know that prefrontal cortex functional connectivity is associated with what? Increased attention, with increased working memory, cognitive control, executive control, emotional regulation, self-perception, and self-compassion. And we know that when functional connectivity um, is decreased, we see anxiety, depression, negative emotion, and hyperarousal type symptoms. So this is yet another benefit. So we saw the coherence pattern, we saw the activity in the OFC, and now we see the enhanced functional connectivity in 6 regions of the prefrontal cortex. Next slide. So our conclusions are BioTouch boosts somatic resilience to better deal with challenges in the environment. And BioTouch harnesses the natural capacities of our mind and our brain to respond to pain or stress through neural activity in the orbital frontal cortex, and it also increases functional connectivity of the prefrontal cortex as measured by near infrared spectroscopy. Next slide. I want to thank those 32 women that gave up their Saturday or their Sunday to come and undergo the scan during a BioTouch treatment. They make me think about these 28 oaks that are planted along the walkway as you leave the river landing, heading up to the house at this beautiful place on the river road called Oak Alley Plantation. Um, these women are mighty oaks. Their bark is rich as they've endured turmoil, struggles, joys, sorrows, and they raised their leafy branches in beauty and really provided a shade and refreshment for us during those really hot August days to illuminate for us how BioTouch is a centrally active modality. It is a wave therapy. Next slide. If you are interested in more details about any of the BioTouch research that I mentioned, I have a whole chapter about BioTouch in my book, Gospel of Women's Health. There's my website with a link to a tree, how to get that. There are some remarkable case studies as well as testimonials as it related to patients that have benefited from BioTouch, and even some case studies of my own kids and how we've used BioTouch in our home. JustTouch.com is your main resource for learning this technique and bringing it to your care setting. The manual, I believe, has been translated into six languages. And as I understand it, right now, BioTouch is being used in various settings in about 12 countries. And Paul Bucky and Bev, your co-directors, are your experts on all things BioTouch. And that ends my presentation. I want to thank you all for your time and attention. And we have some minutes here for questions. I'll turn it back over to you, Paul. Oh, okay.
Paul, we can't hear you.
It's weird. Can you hear me now?
Yep.
Yeah. We want to thank Kenna. You're awesome. Every time you talk, it just brings more to my heart. You remind me why I've been doing this for 35 years, and we hope that we can continue in our research. If anybody wants more information, contact us at justtouch.com. We're going to close out the recording, but if you want to stick around and have personal questions for Kenna, we'll do that. Thank you all for joining us, and just touch.